Okay. Well, it's been a long day and plus, and we've heard a lot of wisdom, often repeated wisdom from different perspectives, and trying to put it all together in some sort of coherent synthesis has been a challenge. So I have attempted to do that, and I'm kind of viewing this as from 1,000 points of blight to 1,000 points of light. And I think there's a lot of agreement here that what is happening now all across the country, and indeed in some other countries, but not as bad as here, is pretty awful. The opioids being the main thing, but for a very long time, care for people with pain has been generally deficient, if not harmful. And in terms of the gap between what could be done, at least as we know now, and what is done, it's huge and has resulted in a lot of continued suffering. And so I think there's a number of reasons that emerged, 1,000 apparently, and they include poor clinician training and understanding of the evidence, an acute physical approach to a biopsychosocial, holistic, whole-person problem. There's been a lot of nocebo effects of frustrating clinical encounters, frustrating for both the clinician and the patient, and clearly the iatrogenic consequences of promoting opioid use and some other risky therapies. There's been poor access to effective non-pharmacological care, and due to limited clinician knowledge, coverage, and availability of qualified clinicians, pain CBT being a major example. And the systems in which healthcare providers work have not been supportive of any efforts to really improve. And I'm not going to list the other 995, they don't fit on here, but I think the point is the costs of continued inaction are high. I think this echoes something that was just said. Now, what about the 1,000 points of light that have sort of emerged during this workshop and illuminate the path forward? We've identified education as being critical, improving the pain curricula, team care, expanding the workforce in key areas so that these effective treatments are available, and for clinicians already in care, continuing education. Removing the cost and access barriers to these treatments, changing accreditation and licensure policies, system support to make it easy for clinicians to do the right thing, which I can't understate the importance of. That could include IT technologies that help with this, including clinical decision aids, having clear referral sources and processes, and patient education resources. And then we've identified a number of ways where places where research is essential. We just heard in this last panel focusing on evidence of value to earn CMS coverage and other payers. And again, there's 995 others that I just tried to hit the main ones. So I think there's a lot of agreement here on the problems and even for the most part on the solutions. Pain care is a big problem, many barriers to change. I think we agree generally on some underlying principles, including patient focus is essential, the importance of taking a broad biopsychosocial approach, and I even throw in spiritual factors, since I think many of us are comfortable saying and thinking that. Importance of supporting self-management and empowering, engaging in patients so this happens. And the need to prepare and support clinicians in their practices, like they can do the right thing. And a large part of that is team care and collaborative care. And I think there's been concern, maybe over-concern, about doing it right and waiting for the absolute evidence that is generally believed to be a gold standard before we do anything. But I think we've talked about, given the uniqueness of each environment, that what worked in one may not work in another. And if we really keep focusing on what is the evidence, what are the underlying principles here, I think we should relax a little bit in worrying about exactly how we do it or what we offer, as long as it contributes to the goals that emanate from these principles. And it's clear that there's a lot of passion in this room for really trying to get a handle and to make some progress on this, to address the problem, not just to talk about it again, and to move now. So what's going to happen after we leave here? I think as far as us as individuals, I think we'll continue to do our good work, hopefully more energized, confident, and empowered after getting the reassurance maybe or additional insights that what we've been doing is viewed by people we respect as the right thing to do. We'll know that we're not alone in this and can call on other participants for advice, support, and collaboration. And you and your collaborators back wherever you go are the experts of what approaches will work best in your unique setting, or at least the specifics, strategies for implementing. So what might we do together? And I'm calling this the strategic Blitzkrieg approach. I don't think that's patented, I don't know. And this is just an idea, and there'll be opportunity to discuss it. But I think why the possibility of convening a task force to identify a few key actions that would have the biggest, broadest, and quickest impact on removing major barriers. There's so many barriers. Time is precious. Maybe a strategic approach, if somehow this could happen, could really help us reach a tipping point by doing that. And this would include some of the things that I've heard here that may be some of the key issues are licensure exams, accreditation, quality measures, CMS reimbursement policies, educate large employers since they, to some extent, dictate to the insurers what they want covered. Use existing data to show return on investment. Patricia Herman was talking about that. There may be other data lying around. But I think dollars, return on investment, speak in a way that just evidence for effectiveness and safety don't. And so use this, so the task force ideally could come up with a strategy for taking the key actions and then do it. Again, with the goal of making the distance between now and the tipping point shorter, if that's how the world works. But how do we actually do this? I mean, it's maybe a great idea, maybe you think it sucks, but if people think that or alternative is a good idea, how do we do it? Well, I think we need a buy-in and sponsorship from the stakeholder organizations. And in our case, this workshop that we're having was driven by the National Academies Forum on Neuroscience and Nervous System Disorders and the Global Forum on Innovation and Health Professional Education. And they, presumably, because of their past interest, will have a current interest in kind of figuring out what are the next steps in consultation maybe with the national academies. So that's all I have to say at this point. There will be time later for some discussion, and we'll welcome your ideas. Thank you.